Good afternoon, everyone. Thanks so much for joining us today for Global Gout Awareness Day and our webinar with Professor Geraldine McCarthy. I think we kick off now. We've got a few people who've joined us. So you're very, very welcome. And like I said, thanks for joining us. My name is Tara Regan and I am Communications and Advocacy Manager at Arthritis Ireland. And today we are marking Global Gout Awareness Day with a webinar, and we are delighted to have Professor Geraldine McCarthy with us today. And just to give you a little bit of an introduction to Professor McCarthy, I'm sure some of you are familiar with her. Professor Geraldine McCarthy graduated in medicine from University College in Dublin, the National University of Ireland, and she received her fellowship in rheumatology at the Medical College of Wisconsin, where she developed an interest in calcium crystal deposition diseases. Geraldine was appointed consultant in rheumatology at the Mater Miscordia University Hospital and Kappa National Orthopaedic Hospital in 1999. Where she still continues to run a busy clinical practice and a clinical research programme. And she also teaches as part of the University College Dublin Faculty of Medicine, where she was the first clinician to be appointed full clinical professor of medicine. Geraldine is also heavily involved in international collaborations in research around the world, particularly in relation to calcium crystal deposition diseases as well as gout. And Geraldine is also the author of over 170 publications, and she's been the winner of several research and teaching awards, and also served as the president of the Irish Society for Rheumatology for 4 years, from 2020 to 2023. So we are delighted to have Geraldine with us today, and we really appreciate her taking the time to be with us. Just a couple of slides just to talk a little bit about Arthritis Ireland. I won't keep it too long. Many of you who know us already will know that we're the national charity and patient organisation for those living with arthritis. We deliver support, training, education and information. And we have a national helpline which is open from Monday to Friday, 10 to 4 p.m, which is available for support, information or to register for any of our self-management programmes. The number to ring is 0818 252 846. And also our website, arthritisireland.ie, has a lot of information and resources, including previous webinars, videos, podcasts, booklets. So there's a whole host of information there about different types of arthritis for anybody who needs help. Also, just a little note about our fundraising. So we do rely on the generosity of the public to ensure that we can continue to provide these essential services and supports to people living with arthritis in Ireland. And there are lots of ways that you can show your support for the organisation. So you can make a one-off donation or a monthly donation, and there's a QR code there on the screen. If you'd like to make a donation, it will bring you to our website. And also we are hoping to get a lot of people behind us for the VHI Women's Mini Marathon in June, and you can still register for that at arthritisireland.ie. Just a couple of quick housekeeping notes. Everybody except for the presenters and speakers are on mute and their cameras are off. We have allocated 30 minutes for Q&A after Geraldine's presentation. So if you have a question, please put it in the Q&A function, and you can do that throughout her presentation or throughout the Q&A, and we will respond to as many questions as possible. The webinar is recorded, and everybody who's registered will get an email tomorrow with the recording, and it'll also be available to view on our YouTube channel after the event. So thank you very much. Without further ado, I'm going to hand you over to Professor Geraldine McCarthy, and she will kick off her presentation, and then we'll follow with the Q&A.
Thank you very much, Tara, for your kind introduction, and thank you for Arthritis Ireland for allowing me have an opportunity to talk about gout, which is an extremely important form of arthritis, and it's nice to know that there's a whole day dedicated to gout awareness. I will say that usually the people that tune in to hear about gout are the ones that are the most knowledgeable, and so I'm hoping that whoever is listening will be able to correct people out in the public when they talk about gout in a way that is untrue. I attached to this first page, I'm showing a cartoon which I think depicts very nicely how painful an attack of gout might be. And this is all anecdotal. I've never thankfully had one, but apparently it's really excruciating. So what is gout? Well, it's the most prevalent form of inflammatory arthritis occurring in the developing countries, particularly, or in developed countries, particularly in men. And what we mean by inflammatory arthritis is rheumatoid arthritis, for example, would be an inflammatory arthritis. And so we find that conditions such as rheumatoid arthritis have typically got more press, as it were, compared with gout. And so that's why we like to educate people a little bit more about gout, because it really is very common. It's 3.6% more prevalent in men than women and tends to occur earlier in men. Unfortunately, the prevalence is steadily rising with changes in lifestyle, improved medical care so that people are living longer and therefore increased longevity. A study done in the US from 2007 to 2008 estimated gout prevalence in the US as 3.9%. That'll be 5.9% for men and 2% for women. And you can be sure that the prevalence has steadily increased since then. Hyperuricemia, or high serum uric acid prevalence in those cohorts, was 21.4%, and much higher in men, of course. Okay. So unfortunately, the prevalence in Ireland is not known, as we have to extrapolate it from other populations. Therefore, it has never been systematically studied. We do know, however, that the prevalence of hyperuricemia, which is the precursor of gout, that is, hyperuricemia is the same as high serum uric acid. It increased between 2006 and 2014 from 19.7% to 25% in men, and from 20.5% to 24.1% in women. And we can assume, therefore, that gout prevalence has increased at a similar rate. Another thing that has steadily increased in Ireland is obesity. And obesity is associated with hyperuricemia and thus gout. And obesity is also steadily increasing in Ireland. So what is gout? So gout is caused by the deposition in the joint of what we call monosodium urate monohydrate crystals. And this happens after long-standing hyperuricemia, or too much uric acid in the blood or serum. Not everybody with too much uric acid or hyperuricemia gets gout. So we don't know what it is in an individual, in their joints, in the proteins in the joints that predisposes to the development of these crystals. But some people do and some people don't, but many do. And the more frequently people have the hyperuricemia, the more likely they are to get gout. The cardinal feature of gout is severe inflammatory arthritis, and that would be characterized, and I'll elaborate in the talk, but typically a painful, swollen, hot joint. Gout is also considered to be a metabolic condition associated with elevated uric acid burden in the body. In some ways, it's similar to diabetes. So we all have glucose in our bodies, but when we have too much of it, we get diabetes. And so the same thing happens in gout, too much uric acid. The too much or the excess uric acid or hyperuricemia typically occurs because of underexcretion of the uric acid by the kidney, and less commonly it's caused because of overproduction of the serum uric acid. Hyperuricemia alone is necessary but not sufficient to cause gout, as I already mentioned. And we recognize disease stages of gout. So first of all, you can have what we call asymptomatic hyperuricemia. And these are the people that have the high uric acid but don't develop the crystals in their joints and therefore don't get gout. Now, there's another subset of patients where they don't have any symptoms, but they have high uric acid. And if you look in their joints with ultrasound, you will find crystals there, but they haven't yet developed an attack of gout or a flare of gout. And then gout is defined by somebody who has elevated uric acid and also the crystals in their joints causing trouble, typically arthritis. And then with the passage of time, the gout gets worse. It involves more joints. It can be characterized by formation of what we call tophi, which are clusters of gout crystals. And I'll show you some pictures of them. A kind of a chronic form of arthritis and ultimately joint damage, which can be quite severe. I should mention that gout can be associated with kidney stones also, but I'm not focusing on that today. So what are the risk factors for getting an acute gout flare? Well, typically there'll be frequently there'll be a family history of gout. There doesn't have to be, but it certainly is an association. If you are at risk of getting an acute gout flare, it could occur first during the course of an acute illness, perhaps after a surgical procedure, trauma, even mild trauma can cause it, or it can just happen out of the blue. It can also happen when it's set up to happen by going on an alcohol binge, or if you've been on an alcohol journey, withdrawing from alcohol. Both of those can precipitate an attack. Also, starting off on urate lowering therapies such as allopurinol without concurrent prescription of colchicine or a similar preventative drug can be associated with an acute gout flare. If you're already taking allopurinol and then you stopped taking it, that can precipitate a flare. Or if you're taking colchicine and stop taking it before you should, that can cause a flare. So there's lots of things that can cause a flare. And the problem is sometimes people, and I'll be probably saying this a few times, but sometimes people, when they start the allopurinol and their uric acid hasn't been low and stable for a while, if they stop it, or if they start it, that can cause a flare if they're not taking colchicine or an anti-inflammatory, or if they stop it all of a sudden because they feel they should stop it because they're getting worse. So there are lots. Keeping things stable is key, but I'll elaborate on that as well. So what are the clinical features of gout? Well, a flare of gout is typically of sudden onset, possibly with some prior what we might describe as irritability of the joint that's going to get the attack. It often occurs at night and typically will start off in one joint, but there can be more than one joint even upon the first flare. The most common joint involved in the first episode is the big toe, or the first MTP joint, and I'll show you a picture of that. In order of frequency, the big toe is first, then the ankle and foot, then the knee, then the fingers, then the elbows, and then the wrists, and then bursitis, and I'll show you an example of bursitis. So they're all the typical joints. The pain is often extreme and it'll prevent walking, it'll interfere with work and leisure. Typically it happens just when you don't want it to, like you've just started on your holidays, you get a bit dehydrated, you have a few beers, and the holiday's ruined for yourself and possibly for your family. So this is a typical gouty joint. So this is the big, when we say the big toe, we mean this joint here, the first MTP joint. And you can see that this joint is a little bit red, a little bit shiny, a little bit swollen. And if you were to touch that joint, it would be excruciatingly painful. The weight of a bed sheet would be too much on it. So this needs to be distinguished from somebody who has osteoarthritis of this joint, a little bit painful, they've high uric acid. That doesn't mean they have gout. These are tophi. So tophi I already mentioned, and these are clusters of gout crystals that can deposit in the soft tissues. They also deposit around the joint, but they can be seen in the soft tissues. And this is a more advanced case of tophi. You can see they're extruding through the skin, and they can get infected and cause concurrent cellulitis. So in this case, we need to treat with an antibiotic. Just of note, this is a fungal nail here. This is an elbow affected by gouty bursitis, and if you took some fluid out of that, you would find lots of gout in it. So the best way to diagnose gout is to put a needle in the affected joint, take some fluid out, and you can, if you look carefully, you can see white stuff in the base of this syringe. And when there's a lot of gout, it can look like that chalky material. And then we look at it under the microscope and we can see all these needle-like structures. This is under dark field. dark field helps us find the crystals, and then we can see them under the microscope. That's taken from a book, but this is actually taken from our own system, a patient of ours. We took a tiny sample from their joint, looked at it under the microscope, and this is a white cell in the joint fluid, and these cells eat the crystals and release all sorts of inflammatory mediators, and so this is what causes the pain and swelling that we see. It should be noted that early on in gout, the attack, if not treated, will subside itself. So imaging studies have shown intra-articular tophi, small ones, before the acute gout attack occurred at all. An ultrasound study was done of 35 patients who had high uric acid with no symptoms, and in 12 of those, approximately 1/3, tophaceous or gouty deposits were seen in the tendons, the lining of the joint, and in the soft tissues. And when another technique called power Doppler was used, it showed inflammation in 2/3 of these deposits. So that raises the issue of when does gout actually start? So even though the patient isn't yet symptomatic, there's inflammation there. These are some images that we use to diagnose gout. This is an ultrasound image, and you can see two lines here. This is called the double contour sign, and in experienced hands, an ultrasonographer can confirm gout without taking a sample from the joint if they can see this lovely double contour sign. And this is another type of technique called dual energy CT, which can show clumps of gout. You can see them in green here around the joint. This is kind of useful if you've well-established gout with lots of crystals, and then if you treat it and redo the image and find that they've shrunk, that'll prove that your treatment is working. Gout can really be very bad though, and I don't think you need to be a radiologist to see the awful destruction that has occurred here. So this is a relatively good joint here, but look at this, it's like dissolved and replaced by the gout. So it's a very, very nasty condition when left untreated. So how do we treat a acute gouty arthritis? Well, the first thing we do is immobilize the joint. So rest, put ice on it, elevate it. We use oral colchicine, that's colchicine by mouth. Back historically, it used to be given by vein, but it was too dangerous. We can also use anti-inflammatory agents such as diclofenac, which would be commonly described by the drug diphenhydramine, for example, or naproxen. Or you can give steroids. If it's just one joint, you can put it in the joint, called intra-articular. You can put it into the muscles, or you can give it by mouth, or if absolutely necessary, by the veins. That wouldn't be usually needed though. So with recurrent episodes of gout, we usually like to start uric acid lowering therapy. And so this would be drugs like allopurinol. There's no actual consensus on when to start therapy. In other words, how many attacks should you get, and how what gap should there be between them? No consensus on that. But once we start it, we typically continue it indefinitely. And we aim to treat to a target uric acid level. So if somebody has gout and their uric acid is, say, 450, we want to bring it down, depending on how bad the gout is, to either 360 micromoles per litre or as low as 300 micromoles per litre. The main thing is that don't just give them 300 milligrams. It may not work for an individual. The other misconception sometimes is that once the patient has started the uric acid lowering therapy, there's no need to stop the treatment during an acute attack developing when receiving this therapy. You simply treat the attack. And the sooner you start treatment for the attack, the more effective it will be. So if you are going to be starting urate lowering therapy, it's recommended that the acute attack that you went to the doctor with should be resolved, but in fact you actually can start the allopurinol during the attack once the attack is being treated. So we'll often do this in hospitalized patients because we may not get an opportunity again. And then we will use colchicine, that would be the favored drug, at doses of 0.5 milligrams, ideally twice a day, but if the patient gets side effects like diarrhea, we'd try it once a day. If not tolerated at all, we use an anti-inflammatory. That's an NSAID, non-steroidal anti-inflammatory drug. This medication is given possibly for a year. It depends on the patient. It has been studied up to, I think, 3 months, but 3 months is often not long enough at all. And then the drugs that we have in Ireland are what we call xanthine oxidase inhibitors. And there are two of those. One is allopurinol, excuse the typo there, that should be O, and febuxostat. Or there's a uricose-uric agent. That is a drug that increases uric acid secretion from the kidney, called probenecid. And in rare occasions, a patient might need both together. It's very important for other problems to be addressed. Very commonly, patients with gout will have high blood pressure, obesity, or be overweight at least, drinking excess alcohol. They will have high cholesterol, and they'll have insulin resistance or diabetes. Just a word about colchicine. There's often confusion about taking colchicine as a preventative, and I'm happy to say this confusion has diminished over time, because we published a paper following a study with pharmacists, followed by an education session. But pharmacists are not familiar with the guidelines, which tell patients to take pharmacists that aren't familiar with the ACR or BSR or EULAR guidelines may tell patients to take the colchicine only when attacks occur. So the patient themselves need to know to take the colchicine twice a day until advised otherwise, unless it's not tolerated. And sometimes patients have gone in to the pharmacist and said, I'm to take this every day. And the pharmacist, not knowing the guidelines, will say, no, just take it when you get an acute attack. So I always write on the prescription all the time. There is a potential drug interaction with drugs such as statins, but it's only potential and it's not a contraindication. So the goal of these medications is to bring the serum uric acid down. And so for that reason, when people start these drugs, they need to have their serum uric acid measured at intervals. And sometimes the GP forgets to measure it. So it's great if the patient says when they're having blood tests, please check my uric acid. And the goal of it is to dissolve all those crystals. So what happens is when you lower the uric acid in the blood, it creates an imbalance between the crystal deposits in the joint and in the blood. And it's like salt in water. The crystals dissolve. And ultimately, they reduce and disappear. And similarly, those lumps called tophi will reduce and ideally disappear too. It also reduces the frequency of the flares, and it decreases the ongoing precipitation of the uric acid into crystals. It should be noted that the mortality associated with rheumatoid arthritis has improved hugely over time. So if you look at this graph, rheumatoid arthritis between 1999 and 2006 was associated with a steady increase in mortality compared with people who didn't have rheumatoid arthritis. And then when you look at 2007 to 2014, the gap narrows considerably. So our treatments for rheumatoid have been really good and have received a lot of attention. But there has been no improvement in gout-related mortality over time, in contrast. So this is, in my view, at least in part because of the lack of attention gout gets, and hence the importance of education sessions. But why would the mortality be increased? Well, it's typically to do with associated cardiovascular or metabolic conditions. So I already mentioned increased weight or BMI or obesity, high blood pressure, dyslipidemia or high cholesterol, insulin resistance, hyperglycemia, which means had too much glucose or diabetes, renal disease, which can be precipitated or progressed by high blood pressure, and any of the atherosclerotic cardiovascular disorders such as coronary artery disease or atherosclerosis of the arteries leading to the brain, putting increased risk of stroke. So greater than 50% of gout patients have high blood pressure. A study in the UK has shown coronary artery disease observed in 25% of gout patients, overweight status is in 71% and obese in 14% of US male health professionals with gout. And then the Framingham Heart Study found gout associated with 60% increased risk of coronary artery disease in men, which was not explained by other clinical measurable risk factors. Another study, the Mr. Fit study of 12,866 high-risk men aged 35 to 57 years of age. Participants with a history of gout had a 26% increased independent risk of myocardial infarction or heart attacks, a 33% increased risk of peripheral vascular disease, that is to say, hardening of the arteries leading to the legs and arms, and a 35% increased risk of coronary artery disease mortality, and also a 41% increased risk of type 2 diabetes. So in relation to colchicine, we've become an awful lot more comfortable with using this drug for prophylaxis because recent trials have demonstrated the benefit of colchicine in cardiovascular disease. So people at risk of stroke or coronary artery disease, even if they don't have gout, can be prescribed colchicine. So we're really very happy with it now, and it's a very useful drug. What about lifestyle? So the people often focus on diet and the like. We do know that management of obesity is important. The use of a weight loss program can prevent gout occurring, can reduce flare frequency and reduce serum uric acid. Avoidance of high fructose corn syrup and sugar sweetened beverages is important. There are specific diets such as the DASH diet or the Mediterranean diet have been recommended for cardiovascular disease. These have had limited effect on serum uric acid or gout, but may be beneficial for associated conditions such as type 2 diabetes and high blood pressure. The avoidance of purine-rich foods such as meat, shellfish, canned fish is of limited long-term benefit, and it's far more important to take the medication. So when people say to me, oh, I'm going to do it with diet, no, they're not. It's not possible. However, that said, when taking the right medication, in addition, avoidance of purine-rich foods is of possible benefit. Also, using skimmed milk, low-fat yogurt, soybeans, and vegetable sources of protein should be encouraged in people with gout. Alcohol intake should be limited. Beer is the worst. And then a regular exercise is good, except for during a gout flare when it's advised to rest. The other problem with gout is there's an awful lot of stigma associated with it. This is a paper that was written about that very problem, that in the media, and oftentimes gout patients are depicted as people who are in fact lazy, overweight, drinking too much, etc. The fact of the matter is an awful lot of gout patients are fit and thin, and that is because we know that there's a huge genetic predisposition to gout. And I've had a number of typically men who are perfectly thin, good, living healthily and all of that, and they still got their gout, and they were embarrassed to come and present and get it treated. And that's something that we really need to avoid. It's in the genes most commonly, and it can be exacerbated by not taking the medication and not eating a good diet, but it is in the genes. So the take-home message about gout is that it's one of our very few essentially curable rheumatic diseases, but the patient needs to have the correct dose of serum uric acid lowering treatment, and the patient needs to persist with treatment. And it's a bit like your high blood pressure. You don't know you've high blood pressure because you don't feel it until you have a stroke. Well, the same thing, or a heart attack, the same thing applies for gout. You'll only know that it's come back when you get an awful bad attack, and you get it when you're on holidays or doing something important. So treatment needs to be continued indefinitely. It is a debilitating condition and is the cause of many missed work and leisure events and opportunities for the patient and their associates. Drug therapies for gout have benefits beyond the joint. Unfortunately, the prevalence is going to continue to rise, and hence our knowledge of it and awareness of it needs to increase. We do need a massive increase in awareness and education, and not only of patients, but of medical professionals. We need to destigmatize it, diagnose it, and treat it. And I put this up because I just imagine this picture, if you were getting an acute gout attack right now, the nice blue sea clouds would be very comforting, along with ice. So I'll leave it there, and I would be very happy to take any questions or have a discussion. I could have spoken for hours about gout. These are just really lead-in points to initiate discussion. Thank you very much.
Thank you so much, Geraldine. That was a fantastic presentation and a really good overview of the diagnosis and then the treatments and the lifestyle interventions, I suppose, that people, have a strong role to play in managing the condition. So I think we go on to our Q&A, if you're happy to do that. And we have some questions here for you. So we have a question here from someone who said they were told by a doctor in a hospital that they had gout in their wrist and thumb. However, their GP said it was osteoarthritis, and they're wondering if that's connected. I'm guessing they're not sure if they have gout, or if it was a misdiagnosis perhaps from that question.
Now, obviously, having not seen the person, I can't be very specific. However, there's no doubt about it that the two conditions can coexist. Yeah. So as people age, they're more likely to have osteoarthritis in their joints, and gout tends to increase in prevalence with age too. So you certainly can have both together, but we like to confirm the diagnosis of gout by either taking a sample from the joint, or doing that ultrasound test showing the double contour sign, or usually at some stage the big toe will be involved. So I can't confirm in an individual case whether it is or is not gout. Yeah. But I have told you how to confirm it.
Yeah, great. Thank you, Geraldine. So we have another question here. Are women more likely to experience gout attacks during menopause?
They're more inclined to experience gout attacks after menopause, because estrogen tends to help the excretion of uric acid from the kidney. And once we don't have all those estrogens, then they catch up with men a little bit. So it's a postmenopausal thing, really.
Postmenopausal rather than during menopause. Okay.
Well, it could occur during too in susceptible individuals with the genes, but typically more post. Yeah.
Okay. This person said that they have a pain across the top of their foot that comes and goes over the course of a few days. Is it likely to be gout? The pain is not so bad as to prevent walking, but still uncomfortable, and then it disappeared. It doesn't sound like it's an acute attack of gout, but it might be something else to it.
No, it's fine. Well, again, assessment it would be needed, but there was a paper published from Ireland actually, where they looked at people with painful toes. They used the ultrasound test and showed that they had crystal depositions in their toes with the ultrasound, and then treated them with urate lowering therapies, and then the pain diminished, and they had never had an acute attack. Yeah. So I can't again swear to it. It's not speaking to me, shall we say? And certainly if it's gone on for a long time, there may be some osteoarthritis there that can be triggered a little bit by footwear being worn on a particular occasion. So can't rule it out, but the uric acid would be the key thing. And I should say that the time to measure the uric acid is in between attacks, because during an acute attack, it can be falsely low. It can be high, but it can be falsely low. Yeah.
Okay, that's really interesting to note. Okay.
Yeah.
Okay, so if you have a suspicion that you may have gout, then the time to get it checked is before you have a gout attack, essentially.
Or in between attacks, exactly. It won't, having high uric acid, as I've already emphasized, doesn't mean you've gout, by the way. But if you don't have high uric acid, you can't get gout. It's necessary. Yeah.
Okay. There's a question here. If you have gout causing stalactites between your ankle and bones and a fusion is suggested, are there other options?
Stalactites?
Yes. I'm not sure if I understand that question correctly. I'm not sure.
Can you repeat, Tara, and I'll try and
sure.
interpret.
So if you have gout causing stalactites between your ankle bones and a fusion is suggested, is there any other option?
I wonder, do they mean osteophytes? Because osteophytes happen in osteoarthritis, and you can have an effusion either with gout or with osteoarthritis. And so if that person has gout, then the gout should be treated for sure, because it's associated with exacerbations of joint damage.
Yeah.
In terms of if osteophytes is what they mean, they won't dissolve. They have to be, well, usually you just leave them there unless they're really causing a problem. Surgical removal is the only way to get rid of osteophytes, and you'd be slow to do that unless it was really causing a problem, because surgery is trauma at the end of the day.
Absolutely. Yeah. There's another question here from someone who has started allopurinol and colchicine as their uric acid levels are high, but they have no gout symptoms, and they had read that fruit should be limited, and they're wondering if they should reduce their weekly intake of fruit.
So they're on allopurinol and colchicine, but they've never had a gouty attack.
Yeah, they've no gout symptoms. They have high uric
symptoms.
acid.
Now maybe. Well, okay. The question is, did they ever have gout symptoms? Because I find often when we start people on urate lowering therapy, they really do very well if they're taking colchicine. So if the person already had an attack and is now doing well, there's no real reason why they should exclude fruit. Fruit's good for you in other ways,
Yeah, absolutely.
So I would say not. The fruit and vegetables are good. Yeah. And the uric acid can be managed by taking the right dose of allopurinol if the person has had an attack. And I suspect they must have had an attack at some stage if they were given those two drugs.
Okay, possibly. There's somebody who are wondering, why does a gout attack normally happen at night time?
So it's not entirely sure. However, when you consider that gout occurs in the big toe, well, the big toe is at the extreme of the body, and it's often felt to be to do with the reduced temperature at nighttime in the peripheries. And so that causes an imbalance between the crystal deposition and the blood.
Okay.
But it's not entirely, these are kind of hypotheses. And then there may be a bit of dehydration as well. For example, if somebody runs a marathon, they might get their first attack after that, So it's all about fine tuning. Yeah.
Oh, that's very unfortunate though, isn't it? When you're out running and doing something really positive, and then you might find yourself.
Well, I know the marathon, of course, is so dehydrating, and I'd say it's not that common, but it can happen.
Yeah. Sure. Okay, so we have another question here. So gout runs in my family. Should I have my uric acid levels checked by my GP?
I mean, not necessarily. I suppose not necessarily. I mean, I suppose there's no harm in knowledge is power. So if you've somebody who is a little bit on the overweight side and now their uric acid is high, it's a little bit of a warning. So maybe actually if it's high and they're, it could be a nudge to improve lifestyle with the overall aim of reducing cardiovascular risk and stroke risk and all the rest of it.
Sure. Yeah. So maybe just something to keep an eye on as well.
Yeah. So why not? Why not?
Yeah, absolutely.
If it dawns on you, why not?
Absolutely.
You're not going to treat it, but it might just
if you don't have it,
wake you up. Yeah.
Okay. Very good. There's a question here for somebody who's asking a question about their mother who has rheumatoid arthritis and who has a very sore big toe. Now, I'm not sure if this is really a gout question. So it's at the very tip, very red, shiny, and very painful. And this person has had steroids twice for it, which I presume was treatment for the rheumatoid arthritis. But they're wondering, would a cortisone injection help?
I have no idea, honestly.
Yeah.
No idea. I don't know what it is.
Yeah.
I mean, the very tip of the toe, at the very tip of the toe is not the joint. You know what I mean?
Yes,
I'd have to see it. I'm reluctant. I'm reluctant to advise anything, because if it's somebody with rheumatoid arthritis, you want to make sure that there's not an area of ulceration, say, or you can get gout with rheumatoid too.
Sure.
So and then if you're somebody who's very immune, who's on a lot of medication, it can alter your immune system and make you at increased risk of infection. So does this person possibly have an infection? So there's lots of
this could be lots of risk.
Could be lots of things. Yeah.
Okay. So I mean, I think in that case they should speak to their rheumatologist,
to their doctor,
rheumatologist or doctor.
Yeah.
Okay. There's another question here from someone who has had chronic pain at a reduced level for 3 weeks following a very inflamed and painful acute attack. Is that symptomatic of a chronic gout condition? It's very hard to know really with that one, I think, as well.
Say it again.
So I've had chronic pain at a reduced level for 3 weeks following a very inflamed and painful acute attack. Now, it doesn't say what type of attack that
what?
is. Yeah. So they're wondering, is that symptomatic of a chronic gout condition? I think that's very difficult.
I mean, gout is a chronic condition.
Yeah.
By definition, it is a chronic condition because the crystals are always there unless you treat it.
Yeah.
And then we can cure it. So if this person truly has gout and it's if you don't treat it, and initially it'll go away altogether, and then as time goes by and as the deposits increase, you can get into a situation just like what that person is describing. So it's all around treatment and the benefits of saying,
Okay. And we have another question here. I've been told that having psoriasis is a risk factor for gout. And is there any truth in that?
So psoriasis is associated with hyperuricemia. And this would be one. Remember I said that 90% of cases are resulting from reduced excretion from the kidney, and that a smaller percentage, around 10%, result from overproduction. So in the case of psoriasis, that's overproduction because you've got a turnover of skin. And so because there's an increased risk of hyperuricemia with psoriasis, yes, there is a small increase in gout risk.
Okay.
But the two can coexist, unfortunately.
Yeah, okay. Another question here about kidney stones, and do they put you at greater risk for gout? And I know you mentioned...
No, it's the other way around.
The other way around.
Yeah, so gout can be associated with uric acid kidney stones. That said, if you've got a different type of stone in your kidney that's causing reduced kidney function, that could increase your uric acid or diminish its excretion. So I suppose it works both ways.
Yeah.
If you know what I mean. Yeah.
Okay, fair enough. So we have a question here. Is there a specific test for gout apart from a urine test? Well, the uric acid is not tested. It's not a urine test, isn't it? No,
it's not a urine test.
Yeah.
No. It sounds like urine.
Yeah.
It's not a urine test. It's uric acid.
Uric acid
not
test.
Urine. Now, that said, if in some centres, not usually now, but people, if they really want to know if the person is an overproducer or an under-excreter, they'll do a 24-hour urinary urate. So you collect the urine for 24 hours and look at the urate. And if they're not excreting much relative to the amount that's in their blood, then they're an under-excreter. but it's not really that helpful, and it's a bit of a mess for a patient to have to do it. So I haven't requested that since I was a trainee.
Okay. I have another question here about, can an injury to your toe cause a gout attack?
Absolutely. And it can be, if you've got crystals sitting in your big toe and you didn't know they were there, and then you stub your toe, that could be that could bring on your first attack. Yes.
Okay. All right. Okay.
It doesn't have to be major trauma, like.
Right. So it could be just literally stubbing your toe, and that could be the trigger.
Yep.
Okay. I'll have to watch that. So
I don't think you have to watch that, Tara.
Well, hopefully not right now anyway. I am thinking, about the holidays, the looming holidays that are approaching. So I'm sure lots of people watching this are hoping that they're not going to have a gout attack, when they're away on holidays or about to head away on holidays, that sort of thing. Let me see, have we any more questions there? You've already mentioned that high blood pressure is a risk factor for gout. That was one of the questions as well. And somebody else wondered, can it affect your knees and ankles? And I think you mentioned that in your presentation.
Absolutely, sure can. Yeah.
I mean, the toe is the one that everybody identifies first with. I mean, I think.
Yeah, but the knee is pretty common too, in fairness.
Okay.
Yeah.
Yeah. So I suppose just to make people aware of that, I suppose, as well, because I think a lot of people might not associate that excruciating pain perhaps in another joint with gout, but it's probably something that we all need to be more mindful of, that it could possibly be gout, because everybody hears about the toe and that the sheet, you can't even put a sheet on the toe, it's so painful. So maybe just the other joints as well, people should be more aware.
Absolutely. And the other thing that often needs to be considered is, or one of the, what we would call differentials, if somebody comes to the emergency room with a hot swollen joint, is we have to outrule infection in the joint.
Okay.
It can mimic an infection, that's what I'm saying.
Yeah.
It usually isn't an infection, but it has to be considered.
Yeah, okay. And I think the other thing, like, I mean, I've heard of people, certainly quite young people, like you say, fit and healthy, who've, woken up in the middle of the night with excruciating pain, and they're not the typical candidates that you would expect for gout, when and so it is really something that I think there should be more awareness around it, really.
Absolutely. And when you say typical as exemplified by what we see in the media, not typical as what we see in the clinic, if you know what I mean. So it is no joke. It's not funny.
No, it sounds like it. But I think that's all the questions we have for the moment, Geraldine.
Okay.
So I don't think, and the only thing I would say then is to point people as well to, we have a booklet on our website, and Geraldine very kindly recorded a podcast with us last year as well about gout. I know it's an area that you're hugely passionate about. So there are more resources on our website. There's a page for gout with a booklet, and then we also have a link to our podcast as well. So if anybody wants any more information, we have information there as well. And just to thank everybody today then for joining us. We were delighted to have you here with us today. Delighted, Geraldine, to have you, and thanks so much for hosting this webinar with us.
Pleasure.
And for giving us your expertise. And just to remind everybody who's listening then, if they do have any queries or any questions, or they want to contact our helpline, the number is 0818 252 846, and our website is arthritisireland.ie. So there's lots of information on our website, but obviously our helpline is there for any emotional or information support about our programs or anything like that. So please feel free to contact us if you need to do so. So thank you again, everyone, for joining us, and thanks to you, Professor Geraldine McCarthy. We really appreciate it.
My pleasure. Thank you very much for the opportunity.
Great. Thank you so much, Geraldine. Thanks, everybody. Take care.